Hello.
Good morning. To say a few words about our speaker, Sir is the Chief Medical Officer of the Mission Smile, a non-profit organization that does cleft lip palate surgeries. He is the former head of the Department of Anesthesia, KMC Manipal. Sir is the first started the BSc Respiratory Therapy program in India in 1995. He is the founder director of Medical Stimulation Center, Manipal University, 2009. And he is the founder president of All India Difficult Airway Association in the year 2010. He has a special area of interest in neuroanesthesia, intensive care, respiratory therapy, airway management, and medical stimulation. Over to you, sir.
Good morning, and thank you, Anju and Aarti, for that introduction. Am I heard? Okay, right. So, to kick off the proceedings for day 3, we have a lecture on uterotonics, obstetricians' demand, and recent recommendations. That was how the topic was created by the organizers. And so when I looked at this, I showed this to my wife, who's an obstetrician. And I said, okay, how do we approach this topic? So obviously there are a lot of demands from the obstetrician. And sometimes we bend down to the demands of the obstetrician, not because she's your wife, but even otherwise. But then there is a certain amount of science involved in the use of uterotonics. And what I will do is I will trace the history down from what we did, what I did as a postgraduate resident more than 4 decades ago, till what the practice is now, to see whether we are current in our practice of the use of uterotonics, right? So we have to go back to the basics. We know that bleeding from the genital tract following delivery is termed postpartum hemorrhage, and following vaginal delivery, 500 ml is considered to be the upper limit for a vaginal delivery to be considered or labeled as postpartum hemorrhage, and whereas for a cesarean delivery it is 1000 ml. And then we have very often in the Indian context, this is data from the Western books, but in the Indian context, when the lady is anemic, even a 300 ml blood loss is sufficient to be labeled as a significant postpartum hemorrhage. We also know that primary postpartum hemorrhage occurs within the first 24 hours. That's what we as anesthesiologists are more concerned with and involved in. Whereas what happens later, 24 hours to 6 weeks, is what is called secondary postpartum hemorrhage. Do I need to move this up? Is okay? Can hurt? Okay, right. If you can't hear me, please let me know, okay? So let's recall some of the related obstetric facts. The causes of PPH we've been taught by our obstetric colleagues are for the 4 T's. And today's topic is primarily around the first T, that is the tone of the uterus. When the tone of the uterus does not return to normal, the uterus remains flabby following the delivery, that's when we get postpartum hemorrhage, and that's when we as anesthesiologists use, and the obstetrician uses the uterotonic agents. The other 3 T's for completion are trauma, tissue, and thrombin. Uterine atony, loss of tone or inadequate tone of the post-delivery uterus is what results in 80% of the postpartum hemorrhage. So it's a major cause of postpartum hemorrhage, and therefore we need to concentrate on that aspect of it. Now what normally happens beautifully in physiology is that once the baby is delivered, oxytocin and prostaglandins are released locally, and these result, oxytocin causes a contraction and a relaxation of the uterus. Prostaglandins produce a consistent tetany kind of contraction of the uterus, and these two normal endogenously released uterotonic substances result in the uterus becoming contracted and preventing postpartum hemorrhage. Now there is also a beautiful physiological arrangement where, if you look at this diagram, you have the uterus in 3 layers of muscles. The outermost layer, the muscles are arranged in the form of longitudinal fibers, like the garters that gents wear, the garters of a trouser. So that is how those fibers run from the ground, run in a longitudinal fashion. In between is the tricky layer. In that layer you have crisscrossing muscle fibers. They just crisscross with each other. The uterine vessels are lying in between these openings, and when the uterus contracts, when under the influence of oxytocin or prostaglandins, these contract and constrict the uterine vessels. So the middle layer is the most important one. The innermost layer is circular in arrangement. So you find that the body physiology is such that you got muscles running in all directions, vertically or longitudinally, around the uterus and in a crisscross manner. And when all these contract at the end of the delivery, following placental delivery, you find that the uterus contracts and the bleeding stops, and this is what's called the living ligature. Now, obstetricians have gone on to embrace what is called active management of third stage of labor. They don't wait for postpartum hemorrhage to occur. They take active measures to prevent postpartum hemorrhage. And one of the things they do is massage the uterus. They massage the uterus, and that it's a kind of a smooth muscle. And the moment you massage that muscle, it tends to contract. Of course, enhanced by the effect of the uterotonics that are released at the end of delivery. So the placenta, obviously for the sake of the baby, receives a large amount of blood to the tune of 600 to 700 ml of blood every minute. And can you imagine that if the uterus does not contract within 2 or 3 minutes, you can practically get half the blood volume of the lady coming out into the uterus and coming out of the vaginal tract. Therefore, we need to have an active management, and one of the things that the obstetrician does is the massage of the uterus. They also ask us, or if they are doing a vaginal delivery in the labor room, they also use oxytocin. And that is the discussion that we are going to be talking about today. What is an oxytocin? A basic definition of an oxytocin, oxytocic rather, is any drug that promotes the contraction of the uterus, right? And there are 3 classes of drugs. All along my lecture, I'm going to be using the term 3 very many times. So there are 3 classes of oxytocics. Oxytocin, which is the naturally related release hormone from the pituitary, and its related drugs. The congeners of oxytocin is one class of drugs. Ergot alkaloids is another one, and prostaglandins are the new babies in the market. Okay, these are the new ones that have come in the market, not really that new, but maybe about 10 to 15 years into the market. Let's first talk about oxytocin, and I'd like to spend a little time on this because the way I used oxytocin, I'm probably the oldest in this audience. Ramdas was my student, of course. So when Ramdas was my student, he also used oxytocin the same way. And I'm sure many of us used oxytocin as a bolus injection. And we are using the same drug. So we look a bit into the pharmacology of this drug to see how, after understanding the pharmacodynamics and the pharmacokinetics of this drug, how we need to change our practice. Even though the obstetrician may demand oxytocin, how as anesthesiologists are we going to change the use of the same drug is what I'm going to dwell upon in the next couple of slides. So as I mentioned here in the first bullet point, it's a naturally occurring endogenous secretion released from the posterior pituitary. It's got a short half-life, which is something that was known, but we were not very aware when we used it. It's got a short half-life of 6 minutes. And what many of us, including me, what I did as a postgraduate resident more than 4 decades ago, was to give a bolus injection, IV, of 5 units. Some of them, obstetricians used to say, no, it's very flabby, the uterus, give 10 units of oxytocin IV. And then the remaining from the syringe, we used to put it into the remaining IV fluids and run it rapidly. Right? Now, this is exactly the way that we should not use it, which is what we've learned along the way. There are many articles that have come out, and I'll explain each of these as we go along. Because of its short half-life, oxytocin is administered as an infusion rather than as a bolus. And I'm sure there may be some people in the audience, if I ask them to lift up their hand, they may say that they are still using it as a bolus injection followed by an infusion. Right. So I think that's a wrong way to use it. Let's try and change our practice. The synthetic preparation available is what we call pitocin or syntocinon. Okay. It needs a cold chain for transport and storage. Now, if you go and look at your operating room and find that the syntocinon that you're supposed to use is lying outside, not in the refrigerator, okay, then you definitely know that its potency has come down. So from a room temperature, even though it may be 20 to 24 degrees Celsius in the operating room, even that degrades the action of oxytocin. It should be refrigerated in a temperature between 2 to 6 degrees Celsius, taken out from there and immediately loaded after that. So it's a drug that needs a cold chain not only for transport but also for storage. Storage is something that we can control, but when it comes from, let's say, a city like a nearby city like Thrissur or Calicut or something like that, are we sure that the supplier is maintaining the cold chain? If it is not, then the potency of the drug is going to come down and it won't act as well as it should. The unwanted effects of a bolus injection is the last point that we need to concentrate on. If you give it as a bolus injection, it causes vasodilatation, tachycardia, hypotension, and sometimes it may even lead to, in a very critical situation, may even lead to a cardiac arrest. Therefore, we need to look at literature, and one of the papers that has come out says that the effective dose, ED90 of oxytocin, is achieved when you give it as an infusion, not as a bolus, less than 1 international unit per minute. Okay, so we usually give it from a, say, an ampule that contains 5 to 10 international units of oxytocin. That this is definitely not to be given as a bolus. The ED90 of oxytocin, once again, the point to remember is that for cesarean delivery, it is 0.3 international units per minute for a lady who is not in labor. A lady not in labor who is posted for a cesarean section for some other reason requires only 0.3 international units per minute of oxytocin to produce the desired oxytocic effect. Whereas somebody who has been exposed to oxytocin during labor, the obstetrician has started an oxytocin infusion to accelerate labor, or the lady has been in labor for some time, natural oxytocins are being released in the body, the receptor sensitivity changes, and such women actually require 0.7 international units per minute to produce the desired effect. But remember, both 0.3 and 0.7 international units per minute are both less than 1 international unit per minute, and therefore we must give it as an infusion rather than a bolus. Now, when we go into more interior parts of our country, we have midwives who are practicing. I was actually born in a place called Ponnani. There were 2 midwives practicing there, and all my siblings and my cousins were delivered by one of the 2 midwives. There were no obstetricians on call in that small village. So in that kind of a situation, Pitocin is available as what's called a uniject preparation. It's a pre-filled 5 international unit syringe which can be given, and only they are allowed to give it IM. A midwife is allowed to give it IM, not IV bolus, but give it as an IM bolus injection. Right. So barring that, we should use it as an infusion. Right. So I had already asked this question earlier. Now a few more people have come. So now I actually ask this question: how many of us have given a bolus of 5 international units of Pitocin, IM or IV, soon after placental separation at cesarean, and then followed it up with 10 units in the remaining IV fluids and keep the tap wide open? I am the first one to raise my hand. Okay. So I find practically 80% of the group is raising the hand, including some younger people who look like postgraduates to me. That means we really need to change our practice, right? And this is evidence based, it is not coming from my mind. It's evidence based. As I raised my hand first, I was also doing the wrong thing, but I think now we have to slowly change our practice and do the right thing. Okay? How do you do the right thing? Again, I said I'm going to refer to the number 3 very often. This is the rule of 3s that has been created by 2 authors, Sen and Balki, in the year 2010, almost 15 years ago. And what they said was, add 30 international units of oxytocin to 500 ml of isotonic saline. Now you should use isotonic saline, do not use 5% dextrose, but because when you dilute it in dextrose, dextrose gets metabolized and leaves back non-electrolyte pure water in the system, and that leads to increased incidence of pulmonary edema. Right. So when you add 30 international units of oxytocin to 500 ml of isotonic saline, you get a concentration of 3 international units in 50 ml. And what Sen and Balki suggested was that we administer 3 international units of oxytocin over 15 to 20 seconds. Okay, and then repeat it at the end of another 3 minutes, and repeat it again at the end of another 3 minutes. That means 3 doses of 3 international units of oxytocin or Pitocin given as a 50 ml infusion. Once you made it up in the dilution that's given on the first line, repeat it 3 times. So you are now finally given 3 plus 3 plus 3, 9 international units of oxytocin. And if this has not caused the uterus to contract, if the uterus is still flabby, then you can take other uterotonics into consideration, which we'll talk about, like methadone or carboprost and the other medications. Once you get adequate uterine contraction, then you continue administering oxytocin at, again, the magical number of 3 international units per hour now for the next 5 hours. So this is a simple thing to remember: 3 units at one time, repeat 2 more doses at 3-minute intervals. At the end of 3 doses, the uterus is not contracted, use alternative oxytocics, and once the uterus is contracted, continue an infusion at a rate of 3 international units per every hour for the next 5 hours. Right. Now this is another nice regime that's come up. I think Aarti, are we bringing out some lecture notes? Yeah. So you will have it on your lecture notes. So I'll spend a little, go through this a bit quickly. You prepare it in the same way as it's given there, 30 international units in 500 ml. Okay. And in 2 different categories of patients. The category of patients given on the left side column: parturients undergoing cesarean delivery without previous exposure to oxytocin or vaginal delivery. You start the infusion at 0.3 international units per minute. Increase it if atony persists to double that dose. From 0.3 international units per minute, you go to 0.6 international units per minute, and then increase it again to 0.9. And at the end of all of this, it still doesn't contract well enough. you take other uterotonics into consideration. The patient is undergoing cesarean delivery with previous exposure to oxytocin. Remember I told you that the oxytocin receptor sensitivity changes when it's already exposed to oxytocin. You start off at a higher infusion rate. Skip the first 0.3 international units per minute dose, go straight to 0.6 and to 0.9 till the uterus contracts. You can consider alternate drugs like methyl ergonovine or methagene as we call it, or 15-methyl prostaglandin F2 alpha. I will give you a little more details about this in the next couple of slides. Once uterine atony is resolved, you can continue oxytocin at an infusion of 60 ml per hour or 0.06 international units per minute. All of this is there in the lecture notes. So if you want, you can take a picture, photograph, so that it remains in your phone. I would seriously, this one thing I would like us to change practice at the end of this lecture is this. So this is an important thing, and that's why I'm spending a little more time on this. How many of us have access to carbitocin? Great. So when I retired, carbitocin is not in the market. Okay. Now carbitocin is available, and they have done drug trials on this. They said that any dose between 80 to 120 micrograms of 5 minutes of micrograms of carbitocin is sufficient to produce it. The advantage of this is that it comes as a 100 microgram preparation. The ampules are shown there for you. It's a heat stable preparation in contrast to oxytocin, and it can be kept for 36 months at 30 degrees Celsius at a relative humidity of 75%. So being more heat stable, I think this is something that may percolate into the interiors of our state, our country, and this is something that we should continue now using if you find the use of oxytocin is not appropriate. It's a good alternative to oxytocin. Methagene was our fallback upon drug. When I was doing my post-graduation, it still remains the fallback upon drug. Okay? It is again like carbitocin, it's heat stable. It is semi-synthetic. It's an ergot alkaloid, as they say. It's produced by a fungus that grows on certain media. So it's a semi-synthetic compound. It's available for us even now as 0.2 milligram per ampule. And when administered as a 0.2 milligram injection IM, intramuscular, never IV, okay, it causes a uterotonic effect which lasts for 2 to 4 hours. So this is our first backup drug. When oxytocin or carbitocin doesn't work, we go on to methagene, okay, and this definitely produces a kind of a tetanic uterine contraction, unlike oxytocin or its congeners which produce contraction relaxation. This causes a persistent contraction, and as a result the atony gets tackled much faster. The last line is very important. IV injection is strictly avoided, and even IM injection to be avoided in patients who are hypertensive, in preeclampsia, eclampsia patients. We avoid the use of this drug. Carboprost, now we come to the third category of drugs, is the prostaglandin. Again, it's a congener of what is normally secreted inside the body. We have F2 alpha and we have E1 prostaglandins, both of which I'll be talking about. This is a synthetic analog, comes as a 0.25 milligram ampule as it is shown there on the right. We can repeat up to 8 doses at an interval of 15 to 30 minutes. That means 0.25 milligram times 8 will work out to a total dose of 2 milligrams. You give it at intervals of 15 to 20 milligrams IM, okay, never IV. It is contraindicated in asthmatics because it is known to produce a bronchospasm, and if the surgeon wishes, he or she can use it intramyometrically during cesarean delivery. It goes directly to the site of action. So they can give it intramyometrically as a one single injection, remaining the anesthetist takes over and gives it IM every 15 to 30 minutes. The cold chain is required once again for this drug. So methagene is one of the safe drugs as of now which can be kept at any point, including carbitocin. The last drug that I will be talking about is misoprostol. It's a prostaglandin E1 analog. This is the advantage of this drug is clearly evident in the next 3 bullet points. It is given rectally, sublingually, or buccal route. Okay, so it can be given by midwives. It can be given in resource poor situations. It is thermostable, and therefore this is something that can be used as a last resort. Let's say you are in a small health center, you want to transfer the patient to a nearby bigger hospital. The midwife or even the doctor available there, who may not be an MD or a DGO, can give this either rectally, sublingually, or buccally, and then transport this patient to a nearest big hospital. Useful option in tropical countries as we live in. So in summary, what I'd like to say, again I'll follow upon the mnemonic of 3 if you wish. We have Prophylactic oxytocin already included as one of the 3 cornerstones of active management of labor, right? So I did not mention the second cornerstone because it's purely an obstetrical view. One is the massage of the uterus, as I said. Second is what's called controlled contraction. Now, if a younger person is doing this thing, or a nurse who doesn't understand what's happening, they just tug on the placenta, that worsens the situation and may result in postpartum hemorrhage. So the second pillar is controlled contraction, and the third one is prophylactic antibiotics. Don't wait for PPH to occur, attack it before it occurs. The 3 classes of drugs are oxytocin and its analogs, ergot alkaloids and prostaglandins. I really wish that after this lecture, we will all use smaller boluses of oxytocin as advocated by Sen and Balki, and as advocated by the University of Chicago guidelines. Thank you very much, and I think I'm indeed grateful to Dr. Akkamaha Devi and her team for inviting me. I know Dr. Akkamaha Devi for a very long time, but now she's invited me to Kerala, and thank you for that invitation, and especially to Aarti and Yasin. They have been in touch with me for practically the last 3 months, and they have made my journey to Wayanad very pleasant. Thank you. Any questions, I'll be happy to take it.
Thank you, sir.
Thank you.
Now,
Yes, sir. Akkamaha Devi has a question, sorry.
Mention about it. Just one thing, sir. Most of the times we are like under the control of the obstetrician.
I thought only I was, because I had a wife who was an obstetrician.
No, sir. That is the thing. So do we listen to them like when the things are going on, like they want the things to be given one after the other? You said wait for a while. So
I think we have to therefore educate them also. Okay, show them some articles. We are all very scientific nowadays. Take out this article by Sen and Balki. I think it's a very useful article. You should have interdepartmental, and I think in any good institution, the obstetric anesthetist and the obstetrician will work hand in hand. Not only for these kind of situations, you have to plan the absolutely right anesthetic for any obstetric situation, particularly when it comes to a difficult airway. So I think you have to work hand in hand, and if they don't agree, I think it's time you educate them, right? And I know it's difficult to prepare this oxytocin. So if you're working in a team, one member of the team, the moment you know a cesarean is coming up, has to dilute this. Not difficult to add 30 international units of oxytocin to 500 ml of solution, right? And then you can, if we all have syringe pumps, right? So we can actually rotate into syringe pump and give it. So I think it needs a change in our way we think. Everything is available, but we are using it the wrong way just for our convenience. Even I did the wrong thing, but I wish the youngsters will change in future. Yeah. Thank you. We don't want to cut into the next lecture. Thank you.
Thank you, sir. Now, I request Dr. Anju to please come onto the stage to felicitate Dr. Ramkumar. Now, I request Dr. Sanish to please come onto the stage to felicitate Dr. Anju and Dr. Aarti.